Okay, I think we'll start. Hello, everyone. A very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy during this time. I'd firstly like to acknowledge the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located and from where we're broadcasting to you today. I pay my respects to their elders past, present and emerging. So we're very pleased to welcome attendees from various parts of Australia and the globe, including India, Indonesia, Burma, Fiji, China and South Africa. And today we will be hearing from two speakers from the esteemed multidisciplinary Apollo hospitals across India. So with such a reach, our weekly webinar series allows us to share and learn from each other's experiences during the pandemic. And we believe that knowledge is power. And so we're thrilled to be able to broadcast this webinar to you all today. I am Bridget Nielsen. I'm a medical student and a volunteer for the ANU COVID-19 Peer Support Program. And joining me are my colleagues, Devashi, a fellow medical student volunteer, and Dr. Dipti Talalaka, who is a haematologist and the lead of the ANU COVID-19 Peer Support Program. And also a special thank you to our corporate sponsor, the National Capital Private Hospital. And I'd just like to extend that if you'd like to become a corporate sponsor, please contact international.health@anu.edu.au. So just before I introduce our speakers for today, a couple of housekeeping notes. Can all attendees please have their video and microphone switched off? This just helps to keep the sound quality clear and reduce any interference during the webinar. I'd like to also encourage all attendees to ask questions by using the Q&A button that you see towards the bottom of your screen. If you do not wish to be identified, that's completely fine. You can submit questions anonymously, and you can submit questions at any time during the webinar. There may be some evaluation polls that pop up on your screen during the talk or at the end of the talk, and we just ask you to select your preferred response and just know that your response will be anonymous. Likewise, if you have any technical issues or questions after the talk, please feel free to email us at international.health@anu.edu.au, and we'll try to assist you with anything we can. And please also finally note that this forum is being recorded. So it is my pleasure now finally to introduce our speakers for today. We have Dr. Rohini Sridhar, who will be talking about the Apollo experience in delivering healthcare during the COVID pandemic. So this talk will focus on the challenges that the Apollo Hospital Group in India has faced in creating infrastructure, training and human capacity and maintaining supply chains during one of the most stringent lockdowns in the world while continuing to deliver world-class outcomes. And we'd also like to welcome alongside Dr. Rohini is Dr. Nambi, who is a consultant in infectious diseases, who will discuss the challenges in clinical management of COVID-19 patients from the Indian perspective. So let's begin with the webinar itself, and I'll hand it over to you, Dr. Rohini.
Thank you, Bridget. It's nice to be here, at least remotely connecting with the Australian National University and this program. I have some connections with Australia because I spent a happy 4 years in Melbourne when I was doing my fellowship for the FRCPA, and I have only fond memories of Australia, specifically Melbourne, but the country as a whole. So it's nice to connect again, and quite happy to share with you our experiences with COVID. As you know, India was one of the worst affected countries with COVID, and it was a big task for our infrastructure to cope with this, and we'll just share with you what happened. I work at Apollo Hospitals, which is India's largest healthcare provider. Currently, Apollo Hospital has 71 hospitals which are spread across the length and breadth of the country. And it's not just hospitals that Apollo does. We have a virtual platform, which is Apollo 24/7 and Ask Apollo. We have a spectrum of labs and clinics, which are outpatient facilities. We also have a large pharmacy chain, and then we have our wellness and advocacy arm as well. As you can see, we clock in fairly large numbers. For our virtual platforms, we have almost 10 lakh active users per week. If you go to the hospitals per se, and this was Apollo hospitals in 2019, we did 470,000 admissions across the group, 10,000 heart surgeries and 35,000 neurosurgeries, a fairly large number of transplants, 1,100 kidney transplants and 260 liver transplants. And as you can see, a large oncology wing as well. So this is what Apollo is. And this is what we were in 2019. This data is actually from early March 2020, when the pandemic had not yet struck India. And this is what we were doing on a yearly basis. Then when COVID struck, which was early March, we came up with a program called Apollo Kavach. Kavach in Hindi means shield, which is what this thing embodies. So it was a shield, and this was a comprehensive and integrated response to protect our community from COVID-19. So there are several different arms to this project, which started with using our digital platform, that is Apollo 24/7, ramping up testing, isolation and quarantine facilities, treatment, and then ending it all with vaccination. So this massive program that we launched called Apollo Kavach was actually written up in NEJM Catalyst as Innovations in Care Delivery, where we took insights from how India's largest private health system was handling COVID. And I will share with you going forward what were the things we did. Now, this was a typical day at the time of when the pandemic struck. And as you can see, the actual consultations by March and April, the number of actual consultations started dropping. The physical consultation numbers, which were here in February, then March, dropped to April and never recovered to pre-COVID numbers till almost the entire year. But there was a rapid switch. These consultations were replaced by a virtual platform, which was almost negligible in March, and then ramped up substantially. This was almost a 100-fold increase. And we had, during the COVID period, almost 5 million new registrations. And at the end, at the peak, sometime in August and September, we were doing almost 240,000 consultations across 75 cities. So this was one way that we were able to reach out to our patients having both COVID as well as non-COVID illnesses. And what surprised us was the ease with which the people of India made the switch fairly effectively. Whatever drop we saw in actual live consultations was more than replaced by the now increase in virtual consultations. And though there was a taper off as COVID numbers increased, as COVID numbers decreased, this ramp up allowed us to reach our patient base, to counsel them, to educate them, and to make sure that they had access to appropriate care as and when it was required. So this is a tribute not only to the people, but also to the clinicians who rapidly adapted from doing actual physical consultations to virtual consultations. The next arm is related to testing. Obviously, at the start of the pandemic, there was no COVID testing that was available in India. And then when testing started off, it was limited to select government labs. And there were stringent accreditation norms to obtain permission for testing in private labs. Now, not having access to testing, as you can understand, during the pandemic posed huge challenges for us, not only in managing COVID patients, but in managing non-COVID patients as well. And because we had one of the most stringent lockdowns in the world, we also had difficulty in transporting samples, as well as difficulty in obtaining reagents during the lockdown. So this was a scenario, and at this time, we got together a group of pathologists across the Apollo group, and we decided that we need to do something on a war footing to make sure that testing was widely available. At this time, testing even in the government facilities was extremely limited because they had very limited capacity and there was only so much that they could do. And without this ramping up of testing, we would not have been able to get a handle on the pandemic. So what we managed to do in this, the initial 2 months of the first wave of the COVID pandemic was to set up COVID testing lab at 16 locations. I think I need to emphasize that at that time, we had access only to the conventional RT-PCR. And I think many pathologists will appreciate the difficulty in setting up a molecular biology lab from scratch in a hospital or in a laboratory which had never done molecular biology before. We also had to set up an infrastructure to collect samples at multiple collection points, including patient homes. At that time, we were also getting a significant number of samples from the government itself because the government system was completely overwhelmed by the demand for testing. And we had to get all these new labs accredited by the Indian accreditation systems, which is the National Accreditation Board for Laboratories and the Indian Council of Medical Research. And most of it we got done within a period of a month. And so far within the system, we have done almost 350,000 tests. I think in the early part of the pandemic, if there were two things which helped us to turn the story around, one was testing, how quickly we got it up. And that impacted care not only within Apollo, but also outside Apollo, because we were able to offer these facilities to government where required across locations. So one was this, and the second was our ability to manage the supply chain, which I will talk about a little later. Now, this effort that we did was actually recognized by the International Hospital Federation, and this is Apollo Hospital Madurai, where I was working, where I still continue to work. And the project that we submitted to them was from zero to hero, how Apollo Madurai set up the molecular lab from scratch in India. And this was awarded under the category of Beyond the Call of Duty for COVID-19, the Response Recognition Program. And this was one of three facilities in the country, not just Apollo, one of three facilities in the country among about 100 hospitals across the world, which were recognized by the International Hospital Federation for this. And this is something that we are actually very proud of. Then we come to the next arm, that is isolation and quarantine facilities. Here we had a lot of challenges. There was obviously an acute shortage of hospital beds to admit patients who were mildly symptomatic. But on the other hand, we had government regulations which mandated that all suspect patients and positive patients should be under some form of medical supervision. There was a reluctance on the part of the district and the state administration to approve home quarantine, quarantining patients at home. And this was understandable because it was very difficult for the already stretched and stressed district administration to figure out a way to monitor these patients at home. And there was anxiety and panic among people because if the slightest symptom they thought could rapidly worsen, and so we need to get to see a doctor, and it's preferable if we are admitted. Now, given this challenge on two folds, one, most of these patients did not need admission at all, and two, we needed to find a way to keep them safe and keep them out of the community. So the solution we came up with was known as iStay, where Apollo Hospital partnered with hotels for isolation rooms. So getting the rooms was easy, but we had to set up the medical infrastructure to make sure that these individuals could be monitored well in the event of them requiring further assistance, further nursing care, and also our ability to identify those patients who needed to be shifted to the hospital. So in all these hotels that we partnered with and we set up this isolation facility across the country, we needed to set up these Apollo nursing kiosks, and we needed to give the patients kits so that their vitals could be monitored, their oxygen saturation could be monitored. We used our 24/7 platform to provide virtual consultations round the clock and also ensured that the patient had access to the medical team once or twice a day, depending on the situation. We also needed to make sure that our COVID guidelines were in place outside the hospital with regard to sanitation and waste disposal. So doing this again across multiple locations at the same time was a huge challenge, but we managed to do it fairly effectively. And at one time, I think we have some data, we had about 29,000 or 30,000 patients who were being monitored under this iStay facility across almost 40 locations in the country. So this actually played a major role in making sure that the hospital beds were not unnecessarily burdened. And it was in the early stage of the pandemic. So as the pandemic went on 2 or 3 months down the line, I think the government also set up a system so that these patients could be monitored at home. And when the home quarantine approvals came through, then we had the Apollo home care arm, which was actually able to remotely monitor these patients at home. Then we come to the inpatient treating challenges. At the peak of the COVID pandemic, almost 50% of Apollo hospital beds were dedicated to COVID management. So now the challenge was, one, to pivot the hospital around from dealing with non-COVID care to actually dealing with COVID patients. At the same time, in the first wave, we had predominantly COVID patients, but in the second wave, we had a mix of both COVID and non-COVID patients. So we needed to work out ways to segregate our COVID patients from our non-COVID patients and pivot both our work processes as well as our manpower to handle these two streams of patients. And in this is how we dealt with it. This is the starting point, and this is just a template which gives you an idea of the kind of work which went into managing this shift or transition from dealing only with non-COVID patients to dealing with both COVID and non-COVID patients, and then moving back to non-COVID patients when the pandemic ended. So we don't need to go through this in detail, but this just gives you the idea of the kind of central planning that went into it. We had this form which was filled in by every hospital. We call this the template in dealing with the COVID-19 surge. So how many COVID beds you have, how many COVID beds you want, and what support you need in terms of engineering, because we had to physically segregate the two spaces in terms of equipment. And I'll share with you a bit of how much equipment was procured during that 12-month period. Nursing staff, whether they need to be redeployed, trained, recruited, junior doctors, critical care doctors. And then the challenge with oxygen. I will come to that in a little detail. How we manage stocks, that is essential drugs, which were absolutely essential, at least in the first wave, remdesivir, tocilizumab. And then how we manage the oxygen supplies, which became a huge challenge for us. Testing we've already referred to, so were we able to do this? And then our positive patient protocols. What was the communication that was going out to patients? How did they get in for a consultation with a patient with investigations that they needed? How do you decide which patients get in for admission? And were we able to allocate the beds as effectively as we needed to do? Our Bible throughout this entire journey was the Apollo book. This red book was actually put together in the first couple of weeks of April 2020 and was revised 14 times in 8 months to keep pace with the changing scenario and the changing demands. This is the index of the book, which gives you the kind of detail that had gone into making our facilities COVID ready, which started with online screening at the entrance to the hospital and then went all the way through fever clinics, outpatient services, dialysis, cancer therapy, because dialysis and cancer therapy were two areas which did not get substantially impacted during COVID. We did not discontinue treating them, and we continued to get a regular inflow of patients for this. OPD consultation, admission, COVID-19 surgical patients, elective surgery. So the entire gamut was covered. And this was a 200-page book that was revised 14 times in 8 months to make sure that we stayed abreast of the changes in the field. And with this, we had to do a large amount of training. So across the Apollo system, we have roughly about 14,000 doctors, about 14,000 odd nurses, and 4,500 and odd paramedical staff, and all of them needed to be trained on the Red Book. So this training was done both centrally and locally over a 3-week period in April. And then we had audits every 2 months. These were virtual audits to ensure that there was compliance and that there was understanding of what the Red Book actually asked us to do. So the Red Book compliance score was generated and reviewed internally. And this is the treatment protocol. It's just a slide for discussion. I think Dr. Nambi will go through it in greater detail. This was our treatment protocol, and this again underwent several iterations through the course of the pandemic as new guidelines came out, and we modified our recommendations to keep in line with what was being recommended by the WHO as well as by the Indian government. And again, I do not want to spend too much time on the clinical details because I think Dr. Nambi will talk about it. But as I said, just to give you a flavor of what happened, if you look at the reported mortalities, this is from the US AHA Cardiovascular Disease Registry with 20,000 odd patients. This is all early pandemic. Of course, we are reporting data till the 25th of September, so there would be some dilution because of that. But again, as you can see from the mortality figures which they reported, which were significantly high, our mortality figures remain very respectable and well below the global average. I must make a point here saying that because we needed to admit patients with mild disease who might not have merited admission in other countries, but given our scenario and our situation, that could be one of the reasons contributing to the lower mortality rate. But even then, if you look at our mortality rate, it is extremely healthy. We also ramped up our facility to provide extracorporeal membrane oxygenation from 3 centers before the pandemic to 7 centers subsequently. And our ECMO mortality for the group sits at 18.8%, which is again well below the global average of 25 to 30%. This was India. I mean, this road is in Delhi. This is actually Rajpath, and this is a road that would almost always be full of people and traffic. And we had, as you probably know, one of the most stringent lockdowns in the world. And in this situation, we had the challenge of distributing materials across 40 locations. Much of this equipment had to be imported. And we also had tight deadlines and fairly urgent delivery of materials required. So the first challenge for us was PPE. And I'm very happy to say that there was not a day that we ran short of PPE or we had to make do with less than the amount of PPE that we required. Much of this PPE is because of India's manufacturing capacity. From manufacturing almost nothing at the start of the pandemic, they were manufacturing 400,000 PPE kits per day at the height of the pandemic. So this is the ramp up that happened. And so we were able to cope with a very difficult situation. Within the group, this gives you an idea of the amount of equipment we had to procure during the lockdown. Obviously, our number one requirement was for ventilators, but we also had to procure a variety of other things to keep our ICUs up and running. And this was a very creditable thing which we were able to do. As you can see at the bottom, we even had to procure beds because we ran out of physical beds and we had to get those beds as well. I'd like to spend a minute to talk about something which really challenged us during the second wave, and that was the shortage of oxygen, which you must have read about. The oxygen requirement in the first wave was about 41.5% of patients required oxygen, 54.5% in the second wave. But though we had about 1 lakh patients at the peak of the first wave, we had almost 4 lakh cases a day at the peak of the second wave. As you can see, this is one bed shared by 2 people, both of whom are, so this is how it looked like. So this was the first case, and then it went up. There's only roughly around 97,000 cases per day at the peak of the first wave, and then went much, much higher for the second wave, in excess of about 4 lakhs. And that really caught us unawares, because if one thing that we hadn't anticipated was that we would run out of oxygen. So you could see these were oxygen queues and people actually standing in queues to procure oxygen. At the start of the pandemic, none of the Apollo hospitals had an oxygen generator. We relied on liquid medical oxygen, which had to be transported in trucks across straight lines. And when the peak of the second wave hit us, we had problems with production. We had problems in transporting it across state lines because many states refused to allow oxygen to be taken out of one state to another. And we also had shortage of both transport and storage cylinders. So the first thing that we did was, of course, this is in close coordination with the government. Committees were set up in each location so that oxygen could be prioritized among hospitals in a vicinity. We set up a 12-hourly oxygen dashboard, which was reviewed group-wide. And we went ahead and procured almost 26 oxygen generator plants. Not all of these 26 were put up, but in critical areas like in Bombay and Delhi, these oxygen generators were set up in a matter of 2 weeks, which actually played a critical role in saving the lives of patients. And almost 1,000 oxygen concentrators were also procured during the same period. So we are, very gratified by the fact that none of our patients had to face this shortage of oxygen, which was actually a big problem at that time, at the peak of the second wave. So once the pandemic was over, the story is still not over. I don't think we can safely say the pandemic is over. It's only the peak of the pandemic that has gone. And we are also aware of the problems of long COVID. So we set out, or we started these Apollo Recover clinics so that we could look after patients who had persistent problems after recovering from the acute illness. So the Recover clinics were set up. And I think, Deepti, somebody asked me about publications. Yes, this is our status with publications on COVID. As you probably know, the All India Institute of Medical Sciences is India's premier medical institute. During the year, that is 2020, AIMS came out with 428 publications. As against that, Apollo had almost 290 publications in Indian as well as international journals. And then the story of vaccination began, because all of us realized that the only way that we could actually get a handle on this was to go ahead with vaccination. Apollo is responsible for the largest private vaccination drive in the world. And after having started in March, till date, we've done about 50 lakh, I think, 5 million vaccinations till date, across 200 vaccination centers, that is within the Apollo system itself. And this is our chairman. We all know that the problem with vaccine rests with vaccine hesitancy. And so we wanted to lead from the front. The day vaccines were made available in India, this is our chairman, Dr. Reddy, taking a vaccine at the vaccination center in Apollo Hospital, Chennai, leading from the front. And today, India has crossed 1 billion COVID-19 vaccinations. And I think the government had a celebration just last week. So we have also participated in that effort, and we are proud of that. And we are looking to commence the pediatric vaccination drive also, as and when it becomes available. So those are my thoughts. So that is what I had on our experience of how Apollo Hospital managed COVID.
Thank you so much, Dr. Nambi, and thank you to you as well, Dr. Rohini. That was a really fantastic webinar. Thank you for your excellent talks and sharing both of your experiences of delivering healthcare during the pandemic. I'm sure everybody will find that both of your talks very useful and educational. So now I'm quickly going to just release a poll to the audience and ask all attendees to anonymously select your response. But we have some excellent questions that have been submitted by our audience this evening. And so I'd now like to share some of them and invite both you, Dr. Rohini and Dr. Nambi, to answer them as we go. So the first couple of questions regard to changing the format of the consultations, as you discussed earlier, Dr. Rohini. So some of the questions are, how did you communicate the change in the format of consultations from physical to virtual? And also, did you offer the virtual consultations at a discounted price?
Well, the thing that we did is, for every patient who actually called up Apollo Hospital to book an appointment with one of our doctors, we offered them this option of virtual teleconsult. And also the patients who were in the outpatient facility, the follow-up visits were scheduled on a teleconsultation platform. The patients who were being discharged from hospital were also offered teleconsultation for their review OP. We also mounted a nationwide advertisement campaign. So we were actually sending messages out to our entire database of Apollo Hospital patients. Some 500,000 of them received messages saying, if you have any healthcare needs, then please log on to Apollo 24/7. This, of course, there was an ad campaign on all media, newspapers, TV, as well as digital, saying, please use 247. And that is where you could suddenly see a sharp spike in the number of 247 downloads from the App Store. So people did get onto this message, and anyway, most of them were online. So I think it made it a little easier. And the second part of the question is, we didn't actually offer it at a discount. I think it was pretty much the same rate.
Yeah. Okay, thank you. Thanks, Dr. Rohini. Okay, some questions about staff and close contacts. Some questions around how did you manage infected staff and close contacts? And also there were some questions about how did Apollo educate and train staff, and how did you ramp up the requirement of doctors and nurses and staff as the wave hit?
I'll take the bit about recruitment and training. Actually, what happened, fortunately for us during the first wave, was that we effectively had no non-COVID patients to look after, almost none. We were in the middle of a very stringent lockdown. We had only a small proportion of patients coming in for emergency care. And so most of our health force, whatever it be, nurses, paramedics, doctors, all of them were reallocated to look after COVID patients. So that's one thing that helped us significantly. Of course, we had to organize some training around that and some reorientation of nurses so that they could look after COVID patients. So that's where the training focused. And anyway, the COVID related training about the COVID protocols, about how to sanitize, how to keep safe, and the segregation, those processes and protocols, anyway, we had to train. So this was the training during the first wave. When the second wave happened, we had to look at recruitment significantly because three things were happening simultaneously. We had COVID patients to look after, we had non-COVID patients to look after, and we had already commenced our vaccination drive. So at that time, we did have to go ahead and recruit. The advantage for us is that though the second wave showed a very sharp increase in the number of cases, it was actually fairly short, probably about 6 weeks, and then it fairly quickly came back to normal. But yes, we had to recruit additional staff during the second wave.
Yeah, again, with respect to the infected staff, how did we handle? That was a problem in the first wave. The second wave, we didn't have a significant percentage of staff members getting infected because thanks to the vaccination program. The vaccination program started in January 2021. The second wave hit us in May 2021. So by that time, most of the staffs, hospital healthcare workers were vaccinated. But during the first wave, we did have our challenges with respect to the doctors and the nurses getting infected. And so there were times when our nurses, they used to stay in hostels where they have shared accommodation, all those things. So we had to focus on isolating people who are infected. Luckily, most of them were of young age and they did well from the clinical standpoint, but they were at risk of spreading infections at their rooms or at a common place where they have food, something like that. So they had to be placed under isolation. And in fact, in Chennai, where we have around 11 hospitals, we did have one hospital. We had a nursing hostel allocated for isolation and quarantine purposes with respect to the nurses and other healthcare workers getting infected. So people who required medical care were admitted and then taken care. People who were just mildly infected or asymptomatic were placed under isolation for a minimum period of 2 weeks. And then people who had come in close contact with them, in terms of significant close contact, we did follow the CDC criteria for defining what is close contact, what is casual contact, and we had placed those people under quarantine. So we had separate isolation facility and separate quarantine facility. And with respect to infection control protocols, this hospital, Apollo Breams Road, is JCI, Joint Commission International accredited. And many of our hospitals are either they come under the purview of JCI, and the Indian government, Indian standards is the NABH. So almost all hospitals in our system do come under some kind of a certification program, either under the JCI or NABH. So we did have existing infection control protocols already in place. So we had to just step it up to the next level. Whereas the problem with the government setup was infection control, a hospital infection control program was kind of a non-existent, but credit to them, they have also stepped up at that point of time. But for us, the jump was little because we did have in existence functioning hospital infection control programs.
Okay, Fantastic. Thank you so much for answering that. We have a couple of questions here regarding routine patients and routine procedures at your hospitals. And the first one is, did you continue with organ transplants and heart surgeries during the acute phase?
I think during the acute phase, all transplants were put on hold. All transplants, especially during the first wave. Because what we have to understand is the first wave, it was a new virus. And I think even though the virus came into India in March 2020, by the time we get to know with respect to the nature, the spread, and we knew that it is only droplet, not airborne, and we knew that it was not surface contamination, all those things. It took at least 4 to 6 months before you understood what it was. So we had held all elective procedures, elective surgeries for the major part of the first wave from May to probably September, October 2020. Emergency surgeries were never withheld, emergency procedures. If someone required a coronary artery bypass graft as an emergency, the patient had underwent the procedure, but most elective procedures were withheld, and all procedures, all surgical procedures, patients did have a screening for COVID prior to procedures. That was because of the fact that COVID positive patients are much more likely to have surgery related adverse outcomes. But the second wave, I would say that with vaccination being kind of ramped up and the healthcare workers, the healthcare system being much more familiar with COVID, I would say that the routine programs with respect to transplants, that would be the heart and lung transplants, the liver transplants, the kidney transplants, the routine surgeries have all been in normal process, except during the phase where we had the peak of the second wave in May and June. Except for the couple of months, the majority, the entire part of this year, all the procedures surgical procedures had been in the normal pace. But first year, definitely it was put on hold.
Okay, so you've commented on some screening procedures for all patients, including routine patients, screening for COVID. So was this your standard operating procedure for admitting patients? Were they screened for COVID? Were they tested? Was testing mandatory? And was there a transition ward before results became available?
There was definitely a transition ward, but what I would put is the screening for COVID was not mandatory for all admissions in this hospital, but the majority that would get admitted would get some kind of screening done because someone would have come with, based upon clinical criteria, someone comes for a procedure. So if there are 50 admissions in this hospital, probably 35 to 40 of them would have had the screening done. And you had a area of the ward of the hospital where people who were waiting for the reports to come were put on. And there were another group of patients where you strongly suspect COVID based upon history, the laboratory reports, or the radiology. And there was another area where you could hold these patients. So there was two set of patients, patients with proven COVID, and then patients who do not have COVID, and then patients who are test has been done, pending reports, but their chance that they would turn out positive is less. Another set of patients who will turn out to be positive is much more. So you should have 4 different areas where you could house different set of patients. That was how this hospital was functioning.
Great. And there's another question here about non-COVID patients. And the question is, how did you palliate terminally ill non-COVID patients? And did you allow next of kin to be with them during the process?
This is for the non-COVID patients or the COVID patients? For the non-COVID.
Non-COVID terminally ill patients.
Yeah, we did have separate blocks for housing COVID and non-COVID patients. Okay, and in general, the areas in which the COVIDs were placed were geographically different from the areas where the non-COVIDs were there. So in terms of the attenders being given a compassionate companion for all these people who are terminally ill, it did have continue. But what I would say is, instead of having 4 members of the family standing in there, it would have been just one member. So we did focus on visitor control policy, where you didn't have the routine visiting hours. For example, the routine visiting hours of this hospital was 4 to 7 p.m. So it was not that entire 3 hours. Probably it was just 30 minutes where a visitor can come in to see the patient. Whereas the attendant, one attendant was allowed for patients who required that kind of assistance for whatever be the reasons.
Just to add, we also made some special permissions for parents to be in when the parents were COVID negative, and we had children, some very small babies who turned out to be COVID positive. So in that situation, those were among the few situations where we had a COVID negative a family member along with a COVID positive patient, along with these end of life situations.
Okay, and I've got another question perhaps for you as well, Dr. Rohini. The question is, what philanthropic role did Apollo play as part of its corporate social responsibility?
Our corporate social responsibility, what we have majorly done is now with the vaccination, we have done a large bit of vaccination, which has been provided to large numbers, essentially free of cost. The other thing was, I wouldn't say it's corporate social responsibility, but we kept our rates of hospitalization extremely reasonable so that we could make it affordable to everyone. But more than CSR, what I would say was just opening the doors of our hospitals, all our hospitals, except maybe the one cancer hospital. Every hospital was admitting COVID patients. I think that was our single biggest contribution, particularly during the first wave, when many hospitals were either unwilling or reluctant or apprehensive of admitting COVID patients. We ensured that every Apollo hospital was available to admit COVID patients. And at the same time, we were able to reach out and reassure the non-COVID patients as well. So I think it is our contribution is to be largely measured in those terms. And of course, the testing that we provided was done at extremely subsidized rates, because we were testing in large numbers for the government, and large amounts of that testing, which was made available in the early part of the pandemic, was made available at very low prices. So I think there we had a significant contribution.
Of course, thank you for that, Dr. Rohini. And I think that leads me on to another question about genotyping in your labs. And was genotyping conducted on a regular basis within your labs?
I think the genotyping in our country is kind of through a network of government laboratories. We have a network called INSACOG, INSACOG, and that's controlled by the central government. Private institutions like us are not allowed to do genotyping right now currently in the country, and the central government has got data on genotype. We do know that in the second wave that we were in our state, 80% were the Delta variants. Our lab is not allowed or permitted, or no other private lab is allowed to do genotyping in our country.
Bridget, we can't hear you.
Thank you. Sorry, I was on mute. So we have a question here about home-based care. And did you offer and manage home-based care to your patients through your hospitals?
Yeah, I think Dr. Rohini mentioned about Apollo Kavach. Okay, the Kavach as a program was primarily targeting home-based care, as well as you had the Project I, where I stay, where people who had mild symptoms, who don't need to be in the hospital for medical reasons, but at the same time they cannot stay in their home because there is fear of spreading infection to the near and dear. So they were accommodated in hotel rooms where you had the nursing team, doctors being available there. That was one thing. And home-based care was offered as a routine in our outpatient services, especially if they have facilities in their room, in their house for an isolation. So all they had to do is a single room with an attached loo where the patient can be put into isolation. So if that facilities were there in their home, then we did routinely recommend home-based isolation. And what we do as a monitoring thing was every day our secretary or the nursing staff would call them to check how they are doing until that period of monitoring is there. Generally, we would do it for 7 to 10 days. We did do that as a routine in the first wave. Second wave, what we have realized is that patients are itself have become much more smarter now, and we do educate them on warning signs so they would come. First wave, we did have it as a mandatory thing for us to call and check with them to our patients who've been advised home-based isolation.
Fantastic. It sounds like such a fantastic initiative. So a few final questions that we have in the chat here, and a couple of them are statistics-based questions really. And the attendees have asked, what was the reduction of non-COVID inpatient cases during the last year?
I think it's a little difficult to answer with a single number, because there were some specialties, like for example, dialysis, oncology, neurosurgery, where we actually saw, and maybe obstetrics, where we actually saw an increase in numbers, largely because many other hospitals were not willing to accept COVID positive patients or COVID suspect patients, and they shut down for various reasons. So since we were continuing to give care, we did see an uptick in these specialties. But yes, there was a significant decrease, as I said, in the first wave, an almost complete decrease, perhaps a 75% decrease in elective procedures. But during the second wave, that is this year, 2021, we really had no significant impact on volumes. So we had COVID, we continue to have our normal non-COVID patients as well.
But there are two departments which are very busy, and irrespective of COVID first wave, second wave. One was the emergency department. The other one is our department, infectious disease department.
Yeah, I should have said that.
And
yes.
we had increase in numbers. Everyone else had decrease in numbers, whereas probably the ER, emergency ED, I think handled almost 2.5 to 3 times more. And our numbers were actually 5 to 6 times more, actually, in terms of our footfalls. Yeah.
And to this, I should add radiology. Most radiology departments, because of all this conundrum around testing, CT scan was done very, very frequently. And I think they had almost a tripling of volume for radiology procedures. Yeah.
Wow, that's huge. So are either of you able to comment or give a number about the proportion of your staff who were infected during the second wave and since?
Probably I can give numbers for this hospital, proportion of the staff who got infected. And let me put it this way. So by the second wave set in, 88% of the staff in this hospital were vaccinated. 88% were double vaccinated. And that was a very good number. And they were all vaccinated sometime in February, March, April. And so they were having good existing, pre-existing antibodies. And there was a big difference between the percentage between the first wave and the second wave. We've had 0.8% of our nursing staff in the emergency, the ICU, plus the other COVID care areas getting infected during this second wave. It was higher during the first wave. It was 0.8%. It was very, very low during the second wave.
Okay, thank you. And our last question, a procedural question. How did you manage endoscopy procedures during the wave and subsequently?
I think, as I told you, elective endoscopy procedures are put on hold. And there was a brief period during the first wave where our medical gastroenterologist had requested us if we could do COVID PCR testing prior to endoscopy. And that was a brief period of a couple of months last year. We did have PCR testing, and then if it is PCR negative, then you could plan the endoscopy. And now what we do is not do testing routinely prior to endoscopy. And with the vaccine being available, most patients being vaccinated, it is not required anymore as a routine. But there was a period of 2 to 3 months in last year. We did do COVID PCR testing prior to UGScopy and colonoscopy. Later part of the first year in 2020, we kind of removed that recommendation. we did realize that it was not evidence based, and it was, so we stopped doing it, stopped doing the testing. And all we could do is have a checklist criteria based on history and clinical symptoms. Based on that, if there is something suggested to COVID, don't do the procedure. Directed to the physician, someone like that. If it is not having COVID based upon the checklist criteria, then you could go ahead with the procedure.
Okay, well, thank you, Dr. Nambi and Dr. Rohini, for answering those questions. And thank you both for your talks today. I'm sure our live attendees and those watching the recording as well, post-webinar, will find this talk very educational and informative. And thank you again for sharing your experiences during the pandemic. And thank you also to our wonderful audience for tuning in today. So I'd just like to give a quick note before we finish up, which is on our upcoming webinar, which will be broadcast next Wednesday, the 3rd of November, delivered by Dr. Brett Schultz from the ANU, who discussed the principles of collaborating with patients, carers, and community members in healthcare decision-making. So please join us this talk to learn critical strategies for creating a holistic and personal healthcare system in the context of the pandemic. And if you're interested, please do register by visiting the ANU COVID-19 Peer Support Program webinar series website. Likewise, if you'd like to learn more about the program, please again visit our website and do not hesitate to contact any of us for more information or support at any time. And with that, I'd like to say thank you to both of you again on behalf of the program and the volunteers of the program. And we do wish you all the best getting through the end of the pandemic.
It's an absolute pleasure to be in this program. Thank you.
Thank you, Bridget, and then you're welcome. Yeah.
Thank you. Thank you. Have a good afternoon.
Thank you. Bye.
Thank you.